How's it going, guys? We have a past level question for Cardiopulm Step 1 Family Internal Medicine 2CK. 22-year-old male comes to the physician after a night of heavy partying, complaining of chest pain. Walks into the office bent over at the waist. He has no past medical history. Vitals are temperature 100.5 Fahrenheit, heart rate 76, respiratory rate 14, blood pressure 125/80. Question wants to know which fine most likely be seen as patient. Let's just hop to the answer choice here. Choice A. Bilateral interstitial infiltrates, wrong fucking answer. So this could refer to, in this demographic, walking pneumonia, mycoplasma pneumonia, where patient is literally walking around just fine, but then you do an x-ray and you see bilateral interstitial infiltrates. Okay, it's very buzzy for atypical pneumonia, and you're just going to treat with azithromycin. In older demographic, patients who have cardiovascular risk factors, that could obviously refer to pulmonary edema. Wrong fucking answer. Choice B, increased pulmonary capillary wedge pressure. Wrong fucking answer. So PCWP equals LAP, left atrial pressure. So that's going to be patients who have any left heart pathology, e.g. MI. So it's going to cause a backup into the lungs, pulmonary capillary hydrostatic pressure, transitation out of the pulmonary capillaries and venules into the alveolar spaces, causing pulmonary edema. Okay, that's the mechanism you need to know. So any left heart pathology does not need to be overt cardiogenic shock. You're going to have increased PCWP. I've harped on this in many of my clips that, in contrast, for instance, in cor pulmonale, where you have right heart failure due to a pulmonary cause, such as pulmonary fibrosis, cystic fibrosis, COPD, etc., you will have normal pulmonary capillary wedge pressure because your left heart is fine. In this case, wrong fucking answer. Choice C, increased serum creatine kinase. Wrong fucking answer. So this could refer to any myriad of MSK pathologies. When we talk about the thorax, it could be pleurodynia. They like that on 2CK in particular. There's a question that shows up on Family Med as well as one on Free 120. That's going to be viral infection followed by intercostal muscle spasm that presents as lateral sharp chest pain. And creatine kinase can be elevated as a result of that muscle spasm. It can be, don't confuse that with viral pleurisy. I've made other clips on that as well. Serum creatine kinase would not be elevated. That could be viral infection followed by inflammation of the pleura. Okay, so that's what comes to mind off the top of my head when we talk about the thorax in relation to increased serum creatine kinase. Wrong fucking answer. Choice D, pulse paradoxus. Wrong fucking answer. So 19 times out of 20, this is going to be cardiac tamponade. So that's going to be Beck triad. So number 1, hypotension. Number 2, JVD. Number 3, muffled or distant heart sounds. Plus or minus pulsus paradoxus, which is going to be a drop in systolic blood pressure greater than 10 millimeters of mercury with inspiration. So the heart can't fill in cardiac tamponade. They'll often say stab wound to the chest, or there can just be trauma from EG and MVA, car accident. And patient has Beck triad plus or minus pulse paradoxus. Students get hyper pedantic about the causes of pulse paradoxus. Say, OMG, Mike, you didn't mention could happen in severe asthma. Doesn't fucking happen in USMLE, all right? Choice D, wrong fucking answer. Choice C, ST segment elevation is correct answer. So you need to know diagnosis, pericarditis. And you get diffuse ST segment elevations in all the leads. Okay, now if you, in contrast, had ST segment elevations in a few contiguous leads, that means 3 or 4 leads, that would be an MI in an older demographic. Okay, in this demographic, you'd have to assume familial hypercholesterolemia, but night of heavy partying, this is very buzzy. Cocaine is one of the important causes of serous pericarditis. Okay, cocaine, viral infections, okay, autoimmune diseases, SLE, RA, these are the most important causes of serous pericarditis. And pericarditis is central chest pain. It's classically worse when you lean back, better when you lean forward. And they can describe it as the patient walks into the office bent over at the waist. Okay, it's leaning forward, obviously. And when we talk about fibrinous pericarditis, that could be post-MI. Okay, so within a few days of an MI, you just get what's literally called post-MI fibrinous pericarditis. You can get 2 to 6 weeks later, Dressler syndrome. It's another cause of fibrinous pericarditis, antibody-mediated. USMLE actually doesn't give a fuck about the type of pericarditis. Serous, fibrinous, suppurative. Like they don't get into those adjectives. They just want you to be able to diagnose the presentation of pericarditis, which cocaine, you need to know. And they'll say very buzzy after a night of heavy partying. So this is what you're going to see on an ECG. And then for 2CK in particular, you need to know you will go on to do an echo because you're going to look for a concomitant pericardial effusion that can sometimes occur with pericarditis. You're going to treat this very similarly to acute gout on USMLE. So you're going to do NSAID first, such as indomethacin, colchicine, steroids. You know the deal. I'm going to make more content. If you like my stuff, subscribe to my channel. Appreciate your time. That's it.